Okay, I didn't practice, so I won't know how to use this thing. Hi, everybody. It's really a great pleasure to be here with you. This is a wonderful conference in a beautiful setting, and I am very excited to be talking to you this afternoon. I'm going to be talking to you about bone marrow abnormalities on MRI and an approach to analysis of these. So if you're a radiologist, particularly a musculoskeletal radiologist, you're looking at knees, you're looking at shoulders, you're looking at hips, and you might be interested in the meniscus or the rotator cuff, but the bones are included, and included with the bones are the bone marrow. And so here are two different cases. We're always trying to decide, is the marrow pattern normal or abnormal? One of these is normal and one of these is abnormal. I'll let you decide which, and if you do decide which, think a little bit about why the one that's abnormal is abnormal. So the challenge here is that alterations in bone marrow are common, and there's a lot of normal variation and few distinguishing features that help us to decide when we're looking at a normal marrow pattern or an abnormal marrow pattern, when we're looking at something that's benign or malignant. And the analysis of bone marrow pattern is based on understanding what the normal and pathologic marrow processes are. So you need to understand really what the physiology and pathophysiology is, and in using a systematic approach to look at the abnormality. So we're going to talk a little bit about marrow basics, and then we'll talk about MR imaging techniques as they relate to marrow, and we'll try to develop an analytic approach to looking at bone marrow, and if we have time we'll look at a few cases. In terms of marrow basics, what's in normal bone marrow? Well, we have trabecular bone, and then we have fatty marrow, yellow marrow that's made up of fat, and we have red marrow that's made up of the hematopoietic cells, and that includes red cells, white cells, platelets, and also some fat. So there's still some fat in the red marrow, and that's something that's important to remember. So here we are looking at a patient who has fatty marrow around their knee, so a sagittal T1 weighted image, and the subcutaneous fat is bright, and the fatty marrow is bright. And here is a fat saturated T2 weighted image, and the fatty marrow loses signal because of the fat saturation, so it's uniformly dark on the fat saturated T2 weighted image. But people also have red marrow, and the red marrow has a different appearance. So here's a sagittal T1 weighted image through the knee, and here's the red marrow, and it's lower signal than the fat, but we're going to compare it to the muscle. So here's muscle, normal muscle, and you can see that the red marrow is hyperintense or a little brighter than muscle, or it may even be a little iso-intense, the same signal intensity as muscle. And on the fat-saturated T2 weighted image, there's our red marrow in the diaphysis and the metaphysis. And you can see it's a little brighter than the fatty marrow. So that's the kind of range of normal. And now let's talk a little bit more about red marrow. We said that red marrow includes not only the cellular elements, but also includes some fat. So normal red marrow, like we were just looking at, tends to be a little brighter than muscle because it's got some extra fat in it. And compare that to a case of abnormal marrow replacement. A tumor or some other infiltrative process going through the marrow eliminates the fatty marrow. And so you have simply cells that have water within them without the fat component. And that translates into the imaging. So here we have another patient who has red marrow in the diaphysis of their femur. This is a T1 weighted image. And the first step is to compare it to muscle. And you can see that it's brighter than muscle. It's hyperintense compared to muscle. So that's a good hint that we're looking at red marrow. It's brighter because the red marrow is including some fat within it. On this side we have tumor. So we can see tumor within the proximal humerus. And if you compare it to the deltoid muscle, it's really the same or really a little darker in signal intensity than the muscle. And that's because the tumor has eliminated any of the fat from that part of the marrow. We also know there's something wrong because the cortex here is disrupted and the tumor is extended out into the soft tissues. But I really want to focus you on the signal intensity of the marrow on the T1 weighted image and comparing it to muscle. So in the extremities, we compare marrow to muscle. What about in the spine? In the spine, we compare the signal intensity of the marrow to the disc, to the intervertebral disc. And so normal red marrow, like you see here, contains some fat, and it's a little brighter than the disc. Whereas when you have marrow infiltration with tumor or some other process, it eliminates the fat, and now you see that the marrow here is iso-intense or maybe even darker than the disc. So that's the key in the spine. Compare the marrow appearance to the disc. If it's brighter than the disc, you're thinking red marrow. If it's darker, then you're thinking marrow infiltration. So there are some pitfalls. If the abnormal process is early and hasn't completely eliminated the fatty marrow, it can be still a little bit brighter than muscle. And the other thing is, we know that tumors can hemorrhage, and if there's hemorrhage within the marrow, it can also be brighter than muscle. So it's not a perfect way to distinguish these things, but it's a very important first step. The other thing to be aware of, to be careful of, is that T2 weighted images that don't have fat saturation are not really that good for marrow. You can get into trouble. So here is a T2 weighted image without fat saturation, and here is a T2 weighted image with inversion recovery fat saturation. So the problem is that most imaging that we're doing now, T2 weighted imaging, is based on fast spin echo or turbo spin echo techniques, and on those techniques both fat and fluid tend to be bright, and so it's easy to overlook marrow abnormalities. So in this case, we see a bright signal there that looks abnormal compared to the background marrow. But on the T2 weighted image without fat saturation, it may be hard to appreciate that this area is also abnormal until you put on the fat saturation and you realize that it's much brighter than the normal marrow signal, the background marrow signal that we see in the patella and the tibia. This was an individual with lymphoma, and you can see the advantage that the fat saturated T2 weighted image has over the T2 weighted image. Because of the power of MRI to look at marrow, people have developed techniques for doing whole body MRI surveys. This is just an example of a protocol that you might use. When you do this, you don't use IV gadolinium because the marrow lesions could enhance and disappear. In the States, this is a little bit challenging to do for a couple of reasons. Time on the magnet, the billing problems, and then who's going to read it. In an academic imaging center, academic radiology department, we musculoskeletal folks look at the brain tissue and say, hey, wait a minute, we don't want to see that at all. And the body imagers look at the MSK stuff and don't want that at all. So it's not that we do a lot of this, but people have demonstrated this as a technique, and some locations are doing it to see sort of a whole body analysis of marrow abnormalities. Another important thing to think about, to understand when you're looking at marrow, is this normal physiologic conversion of marrow. That as we age, there's a progression from red marrow to yellow marrow. So when at birth, really almost all of the marrow space is composed of red marrow. And as we age, we get more and more of the yellow or fatty marrow. So in this individual who's 21, you can see that their lower extremity has a lot of fatty marrow in it. And this standard progression follows a very regular standard course in all individuals, so that the first conversion from red to fatty marrow happens distally and progresses proximally. So as this person gets older, you can see now the femur has more yellow marrow, and it progresses from appendicular to axial, so your limbs turn from red to fatty marrow earlier, and the axial skeleton converts over to fatty marrow later. And even within the bone, there's a progression. First the epiphysis or the apophysis, like the greater trochanter that you see here, the apophysis. Then the distal metaphysis, then the diaphysis. So you see that demonstrated here. The diaphysis turns fatty, and then the metaphysis turns from red to fatty marrow. And this progression occurs in everybody, and it occurs uniformly as you age. And here it is shown on MRI. A 2-year-old, a 14-year-old, and a 42-year-old coronal T1 weighted images. And so here in the distal femur, the diaphysis and the metaphysis, we see the red marrow. In this 2-year-old, actually, we still have cartilage as the background in the epiphysis, but that portion of the epiphysis that has ossified has already turned from red to fatty marrow. At 14-year-old, you can see the change in the tibia. So now we have fatty marrow in both epiphyses, and in the tibia we have fatty marrow, but we said that this progression goes from distal to proximal, so we're still seeing red marrow in the distal femur. And by the time this individual gets to 42 years old, and even before that, we're seeing fatty marrow in both bones around the knee. So this is what I want to impress you with is how dynamic marrow is in its behavior and its makeup, and how important that is really as a biomarker for what's going on with the patient. And this really emphasizes that, the process of marrow reconversion. What we see is that marrow pays attention to what's happening in the body, and it responds to a demand. When the body needs more hematopoietic elements to be produced, it responds. And that fatty marrow that developed over time turns over, it turns back, and it becomes replaced by hematopoietic marrow so that it can provide the blood elements that the body needs. And remarkably, one of those amazing physiologic things, that reconversion from mature fatty marrow to red marrow occurs in that same sort of reverse orderly sequence, in the reverse conversion we were just looking at. So when do you see marrow reconversion? And sometimes it's retention of the red marrow. You see it in obese females, in smokers, in patients who have hemolytic anemia. You see it at high altitude. So in the States, I always say, if you were to go live in Denver, Colorado, which is at a very high altitude, you would rev up your red marrow. In athletes who are training, in patients who are having marrow-stimulating medications, and that can be important to know from the patient's clinical history to find that out. And when portions of the normal marrow have been replaced or destroyed, you'll get increased red marrow in other places to compensate for it. So very dynamic process, which leads to some of the confusion that we get when we're looking at that. So let's see here. Okay, so now we're still trying to decide when the marrow is normal or abnormal. And one of the things that you can look for is the epiphysis fatty? Red marrow in this case is in the diaphysis and the metaphysis, but normal red marrow spares the epiphysis. And just so it's not confusing, the changes that you see here are just some subchondral cysts and edema related to arthritis. But really we've got fat in the epiphysis. What about this patient? This was a 42-year-old woman who was referred for a knee MRI because they were looking for a meniscal tear, and these were the images we got. And we said, well, wait a minute, at 42 years old, this woman really should have fat in her epiphysis the way she does in the tibia. She shouldn't have lower T1 signal in the epiphysis the way she does in the femur. And this turned out to be lymphoma infiltrating the distal femur. So red marrow spares the epiphysis. If you see low T1 signal in the epiphysis, you should start getting concerned about some other process going on. Of course, there are always pitfalls to deal with in MRI, and so one of the variations that you can see in a normal situation is some red marrow right under the cortex in the subchondral bone. You're allowed to have some red marrow, but the main portion of the epiphysis here is still fatty marrow. The other thing we look for in a normal appearance of marrow is that it maintain bilateral symmetry. So when we look at the two femurs here, although there's a heterogeneous marrow pattern, it's quite symmetric, and that can be reassuring. The challenge is that marrow isn't always symmetric. Occasionally you can get asymmetric islands of red marrow. So here's a coronal T1 weighted image in another patient, and we see background fatty marrow, but there's a large area here that is lower signal. So the first thing you're going to do is compare it to the muscle and see if it's hyper intense, if it's brighter than muscle, reflecting some fat within the marrow. And you're also going to look for fat within the lesion. And in a minute we'll be talking about the use of in and out of phase MR sequences to evaluate marrow. And we haven't talked about it yet, it'll come at the end, but some people propose using diffusion imaging to evaluate marrow. So here's a close-up of that same patient. We're looking for signal intensity compared to muscle. It's hyper intense compared to muscle, so we're thinking red marrow. And in this case, we can actually see foci of fat within the lesion, so that's very suggestive of red marrow. If you reach this point and there's still some question, it can be useful to perform in and out of phase MR imaging. Some people call this chemical shift or opposed phased imaging, and if you do body imaging, you may be familiar with using this technique to look for fat in adrenal adenomas or to look for fat in the liver. And the principle is that when fat and water are present in the same voxel, some people call this microscopic fat, then the signal will decrease on the out-of-phase images. So we'd expect red marrow to decrease on out-of-phase images because we have the hematopoietic elements together with fat, whereas a marrow replacement process like a metastasis, leukemia, lymphoma, something like that, we won't see a decrease because it has that process has eliminated any fat from those voxels. So here's an example of in and out of phase MRI. We do this with gradient echo, with T1 weighted gradient echo images. And what I want you to do is compare the right iliac bone to the left iliac bone on the in phase and the out of phase image. So the subcutaneous fat is bright on both images. The right iliac bone is definitely lower signal than subcutaneous fat. The left iliac bone, lower signal than subcutaneous fat. And when we look at the out of phase image, we see that we do get drop off of signal in the right iliac bone. It's lower, gets darker on the out of phase image. On the left side, we see a subtle change, but basically it does not lose signal. It doesn't get darker on the out of phase image. And that's really telling us everything. Basically, the normal marrow is going to lose signal on the out of phase image. The lesion that's replaced here does not lose signal on the out of phase image. And that's really very helpful in trying to analyze whether the marrow you're looking at is normal or abnormal. So we come back to this basic question, and now you have some criteria for looking at these things. Number one, these are fat-saturated T2 weighted images, so you're probably going to say, well, you gave me a lot of criteria to look at on a T1 weighted image, so that would be the first thing you might do. And also when we look here, we see that the abnormal signal is extending into what should be normal fat in the epiphysis, and so we know that we have abnormal marrow infiltration. This is again lymphoma on this side. This is just very pronounced red marrow in the diaphysis. So what about an analytic approach? We've sort of teased that out, but what I'd like to do now is talk about the different processes that affect the marrow, and then we'll talk about signal intensity and distribution of the marrow abnormality, and finally emphasize the look for special imaging features, additional features, using the history, the labs, to try and decide what you're looking at. So in terms of marrow processes, there are marrow proliferative disorders, marrow replacement disorders, so another process different from the cells in the marrow that comes in and replaces the marrow. Marrow depletion, where those elements of the marrow decrease and disappear. Vascular abnormalities, where we're really talking about increased or decreased blood flow in the bone marrow. And then a few things that fall into no particular area and so get their own category. But myeloproliferative disorders, when we're talking about this, we're saying it's the normal hematopoietic elements in the marrow that are proliferating. So if it's plasma cells, multiple myeloma. If it's white blood cells, leukemia. If it's red blood cells, Polycythemia Vera. And if it's collagen and fibrous tissue, then myelofibrosis. So these processes tend to be hypointense to muscle on T1, dark the way we were looking at before. Their T2 appearance can be variable, and it's the marrow itself, and so it tends to be a diffuse process. Marrow replacement disorders are when non-marrow cells invade into marrow. So benign things would be osteomyelitis or a benign primary bone tumor. Malignant things would be metastasis, lymphoma, primary bone tumors. And these are either iso or hyperintense to muscle and to disc, and on T2 they're variable, although they're often high signal on the T2 weighted images, and they're usually focal. They kind of go to a certain place in the bone, and that's where the abnormality is. What about marrow depletion? This is ablation or failure of the red marrow elements, and basically once you lose the red marrow elements. The marrow is going to look like fat on T1 and on T2. And these can either be diffuse or regional, and we're talking about aplastic anemia or changes due to radiation therapy or chemotherapy killing off the red marrow elements. Vascular abnormalities, this is an edema pattern in the bone marrow due to either hyperemia or ischemia. So bright on the T2 weighted images. These are often focal, seen at the epiphysis, and we can see these because of trauma, bone contusions, the subchondral marrow edema you see in osteoarthritis, osteonecrosis, transient edema, and the hyperemia around a joint that has inflammatory arthritis. And then other things to consider would be Gaucher's disease, hemosiderin deposition in the marrow, serous atrophy where the bone marrow becomes atrophic. Paget's and osteopetrosis can also affect the appearance of marrow on MR. So what about signal intensity? Well, now you know this is a coronal T1 weighted image, and which side is normal and which side is abnormal. So if we look at the left side, we have a marrow signal that's a little brighter, a little hyperintense to muscle, and we have fatty marrow in the apophysis and in the epiphysis. So that's behaving like red marrow. On the right side, the marrow signal is iso-intense or maybe even hypo-intense, darker than muscle, and it's going all the way up into the epiphysis, all the way into the apophysis. And so this was lymphoma in the right proximal femur. We talked about how you can see some abnormal high signal on T2. What I'm showing you here is a case where the marrow signal is abnormally dark on a T2 weighted image. So we know it's a T2 weighted image because the urine in the bladder is bright, and we see a pretty normal looking pattern of marrow around the hip. But what about the spine? We can see that the marrow signal in the vertebral bodies appears atypically dark. What can give you low signal on T2 weighted images in the marrow? Well, certainly sclerosis, like you might see in a bone island or in a sclerotic met. Sometimes if you get air in a subchondral cyst, it'll appear abnormally low because of vacuum phenomenon. And then really the diffuse processes that give you low T2 signal: hemosiderosis, myelofibrosis, mastocytosis, and osteopetrosis. And so there's our abnormal spine. So what's the tip-off to explain why this patient has low signal in their vertebral marrow? Very good. Okay, so we have abnormally low signal in the liver, in the spleen, and in the marrow. And so the disease process we're looking at is hemosiderosis. And sometimes you can imagine you're the musculoskeletal radiologist, you're looking at the images, and you may get the first idea, you may get the first hint that something's quite wrong in this systemic process. What about the distribution? When we're talking about distribution, we want to make a distinction between diffuse processes, like you see here, a focal process, or a multifocal process, because certain kinds of processes give a pattern that's more like one or the other. So diffuse marrow problems, normal marrow, obviously, marrow reconversion, and myeloproliferative diseases. So here's a coronal T1 weighted image in a 70-year-old. By age 70, you expect axial marrow to be bright on T1, similar to the subcutaneous fat, but we see this abnormal signal, and this was Polycythemia Vera in a 70-year-old, so proliferation of the red blood cell elements. Focal distribution, that can be a lot of processes we're all familiar with. And then multifocal distribution, again, Mets, myeloma, or multiple foci of the focal processes. But what I want to emphasize is looking for special features and looking for additional findings, because this is often where the radiologist and the radiology resident can make a big difference. So coronal, fat-saturated T2 weighted image of the knee with lots of marrow in the femoral condyle, but we see a low signal transverse line, and that's the fracture line that tells us that this is an insufficiency fracture. In this fluid-sensitive image of the hip, we see serpiginous kind of high T2 signal, and that's our tip-off that we're looking at osteonecrosis. In this sagittal T2 weighted image with fat saturation, we see marrow edema in the lateral femoral condyle and posterolateral tibia, And the marrow edema itself is not that specific, but the pattern taken together is very typical of a pivot shift injury, and these are bone contusions. And in this last image, this is a post-contrast fat-saturated T1 weighted image. We see abnormal signal in the proximal humerus, but we also see abnormal signal extending outside the bone, soft tissue extension, indicating that this is an aggressive process. In terms of looking for a fracture line, I want to emphasize the importance with regard to vertebrae. And if you see a compression fracture, is it benign or malignant? Well, in a benign compression fracture, the fracture line is almost always visible if you look for it. So here's the T1 weighted image, we can see the fracture line. Here's the fluid sensitive image, we can see the fracture line with surrounding marrow edema. And that is really helpful in trying to decide benign or malignant compression fracture. With the case of a pathologic fracture through a vertebral body that's been involved by malignancy, first of all, the vertebral body tends to be expanded with convex margins. It may involve the pedicles. There may be a soft tissue mass. But you often do not see a horizontal fracture line in these pathologic fractures because the fracture occurs late. With the tumor taking over the vertebral body, the trabeculae have already been destroyed, and it's really the compressed trabeculae that are the source of the fracture line. So I also want to emphasize looking for additional findings. These are two different patients. This is coronal T1 weighted image through the, that's one way to get me done. T1 weighted images through the distal femurs in a patient, and we can see that the signal is abnormal. What about the shape of the bone here? So we've given it away. It's supposed to be a secret. Okay, yes, so we don't have the normal concavity at the metaphysis. We have an Erlenmeyer-Flask configuration, and that's typical for Gaucher's disease. In this case, we see abnormal low signal in the marrow of the vertebral bodies, and the additional finding was that the spleen was enlarged. And so here we have a case of Gaucher's disease, and here we have a case of myelofibrosis, which is associated with an enlarged spleen. And even though it's kind of a cliche, I do want to emphasize history. History can make a big difference. Here is a patient with fat-saturated T2 weighted images. Here's marrow edema pattern in the distal femur extending to the subchondral bone. If this is a case of trauma, it's a contusion. If the patient has undergone surgery and had a chondroplasty, this could be an expected post-treatment finding. What do you think here? Much easier if you know that they have a history of surgery and chondroplasty. This was actually the expected postoperative appearance. So let me just ask our organizers how they want me to handle time. I have a few cases I can show. Go for it. Okay, multiple myeloma. Multiple myeloma is very common. You're definitely going to run across it. People have described 4 characteristic marrow patterns you can see in multiple myeloma. Not so easy in real life to distinguish these. Several patterns can coexist, but I want to show it to you. I want to show this to you for the micronodular or peppered appearance, which is somewhat specific for myeloma. So here it is. This is an image through the proximal humerus, and proximally we see the micronodular or peppered appearance, distally a more diffuse appearance. But when you see something like this, it should bring to mind the possibility of multiple myeloma. All right, here's a patient that really demonstrates how dynamic marrow is. They came to us in 2009 because of back pain, and then they came back in 2011, and you can see that the T2 weighted appearance of the marrow is not that different. But if we focus on the T1 weighted images, this was early, and before they had onset of their disease, and here we see diffusely abnormal T1 signal in the vertebral bodies. This patient had Polycythemia Vera. So this is clonal proliferation of the red blood cells. It can happen at all ages with a mean of 60 years old, and it's characterized by intermediate to low signal in the marrow, particularly on the T1 weighted image. It's a diffuse disease process, and so the distribution is diffuse. So you can really start to see how marrow ends up being a biomarker for patient health. Lymphoma is common as well. Most of the time when lymphoma goes to bone, it's a secondary process with an extraskeletal primary happening elsewhere. So only a small percent is primary lymphoma in the bone. It can be focal or multifocal, and although it can occur in different places, it's often in the femur or the spine. Low signal on T1, variable signal on T2, but one feature that would make you think about that is not only the presence of a soft tissue mass, but characteristically that the cortex appears intact. So you have an abnormality in the marrow, you have an abnormality extending and giving you a soft tissue mass in the soft tissues, but it doesn't break through and destroy the marrow. Rather, the marrow tends to be intact, and they talk about the lymphoma seeping out through the bone or permeating through the bone. We also encounter changes related to post-radiation. You may have seen a patient who got radiation for prostate cancer, and if you look carefully, there's a sharp line of demarcation in the port of radiation with fatty marrow in the radiation port, and this is another example in the spine. So radiation preferentially destroys red marrow, and you're left with fatty marrow. And the appearance will depend on how soon after the radiation. So here are a sagittal T1 weighted image and a sagittal stir image through the spine in the same individual. And how would you think about these vertebral bodies down here? They look pretty normal. They have red-like marrow, hyper-intense to the disc, and low signal on the stir. But what about the lesions above that? Here we have fatty marrow in these vertebral bodies and diffuse edema, and so these vertebral bodies are in the portal of the radiation treatment. Now, it could have been treatment of some soft tissue mass, but we see the changes in the bone if it's in the radiation port. So the appearance of marrow after radiation depends on the dose and the time interval. Early on, in the first 2 weeks, you may see no change. Between 2 and 6 weeks, the red marrow starts to disappear, and 6 weeks and later, you see homogeneously high T1 signal, the red marrow's gone, and all you have is fatty marrow left. And depending on the dose, so less than 30 gray or greater than 50 gray, the red marrow, if it's a smaller dose, can regenerate within the year. If you've given them more than 50 gray dose, you probably will not see red marrow regeneration. The red marrow tends to regenerate at the periphery. The other thing that can be very confusing, and I won't tell you that I fully understand it, I just know it's a problem, is that when patients can be treated, patients on chemotherapy or aplastic anemia can be treated to boost their marrow with a granulocyte stimulating factor, and that can really give a confusing appearance because it will mimic Marrow Reconversion or myeloproliferative disorder. And these changes can be rapid and can be striking, and really what you're looking at, what you think is either reconverted marrow or even tumor extension, but the problem is that this is really a response to the treatment that they're getting to boost their marrow. There are a few newer developments we won't have time to talk about, but I want to mention them. People are starting to use diffusion imaging to look at marrow. They're looking at dynamic enhancement of marrow and even arterial spin labeling, spectroscopy. There are some exciting developments in CT and dual energy CT to try and understand what's going on in marrow. And just this important concept that marrow is a biomarker. This is an image from the literature talking about the utility of diffusion weighted image to follow response to treatment in metastasis. The diffusion is restricted in the MET, and as the patient is treated and responds, you see less restricted diffusion on the ADC maps. That's a topic unto itself. So I just want to summarize and talk and remind you that there's a wide range of normal marrow appearances, and the presence of intermixed fat within the red marrow can be very helpful in trying to identify normal red marrow, even when it's asymmetric. There's an analytic approach to apply in terms of understanding what can go wrong in the marrow, looking at signal intensity and distribution, and really working hard to see characteristic features, additional findings, and figuring out what the real history is. The diagnosis may still not be absolute based on imaging, but you can use imaging to guide biopsy to the most suspicious looking areas. And just remember that this is a very dynamic, I think it's exciting, tissue, and marrow really can be used as a biomarker of disease in many ways, like our patient with Polycythemia Vera. So toda raba, merci, and enjoy.